Allow me to introduce a modular approach to rapid deployment of MRI-guided robotic assistance for minimally invasive surgical interventions. Let's begin by analyzing a currently utilized manual deep brain stimulation electrode placement procedure. The procedure begins when the patient arrives at the hospital for a pre-surgical MRI scan, whose images are assembled to create a three-dimensional model of the patient's internal anatomy, which is then used to create a surgical plan. Several days later, the patient returns to the hospital where a fiducial frame is attached to the patient's skull, and the secondary imaging protocol, such as CT or fluoroscopy, is used to register the patient's bony anatomy to the pre-surgical plan. Registrational information is then used to guide and target the surgical equipment during the procedure, after which a new set of MRI images should be used to confirm the correct electrode placement. However, this is not available due to the unavailability of MRI-compatible surgical equipment. Were MRI-compatible surgical equipment available, the entire secondary imaging procedure could be circumvented, closing the loop around diagnostic MRI and allowing the use of the same imaging modality to plan the surgery as to execute it. So why is creating MRI-guided equipment so difficult? The safety issues associated with using ferromagnetic material prohibits the use of most high-strength steels and high-performance servomotors and magnetically based actuator control systems. To circumvent this, high-strength plastics and ceramic driving systems are utilized. However, these systems and the electronics associated with driving them often cause a large amount of electronic interference with the scanner, causing incredibly noisy images unsuitable for use during MRI-guided interventions. The noise observed in the previous MRI images is caused by a combination of EMI radiated by control hardware itself, as well as high-frequency electrical artifacts being transmitted with the motor driving waveforms from common off-the-shelf ceramic motor drivers. To circumvent this, the AIM Lab has created a generalized ceramic motor driver capable of driving a variety of different ceramic motor types and styles without transmitting these high-frequency artifacts. Several of these are combined into a multi-degree of freedom centralized controller, which is then encased in a continuous Faraday cage which serves to block the EMI emitted by the controlling hardware. The product of this is an MRI-compatible controller capable of producing ceramic motor driving waveforms free of these high-frequency artifacts. When the system was placed in the scanner board to test the compatibility of the new actuation systems, the images taken of the Phantom with all of the motors running in place inside the scanner were virtually indistinguishable from the baseline images taken of the Phantom with none of the equipment even in the scanner room at all. Let us now consider a neural stereotaxy system being developed with AIM Lab's modular technology. The system is a 6-degree of freedom unit which is kinematically equivalent with the Lexel surgical frame, the current standard of care for DBS electrode placement therapy. By maintaining kinematic equivalence, preoperative planning can remain the same, which will streamline the adoption of the system by the surgical community. As can be seen with the robot operating within the scanner board, patient anatomy is still clearly visible and discernible with the MRI images, and in fact the images can be used to create and follow an insertion pathway. Currently, the AIM Lab is preparing for clinical trials and for a 510(k) application for one of their surgical systems. We would like to take this time to thank our collaborators and the CDMRP for partially funding this project, as well as you for your time and consideration.